Hi, everyone. This is Dr. Ben Abramoff here with Dr. Juan Polanco, who is going to be discussing the role of autonomic function on sports performance in wheelchair athletes with spinal cord injury. With that, Juan, take it away.
Thank you, Dr. Abramoff. So my name's Juan. I am going to be presenting on this topic, and I want to thank Dr. Abramoff for helping me also find this topic as well. So with that, we can get started. I'm going to be talking about the role of autonomic function on sport performance in wheelchair athletes with spinal cord injury. So just want to give a brief overview. First, we're just going to touch base on the overarching theme of spinal cord injury and how that relates to autonomic regulation. And then briefly speak on some autonomic markers that are relevant to sports performance, mainly in the general athletic population, but then also how that pertains to the spinal cord injury patient population. And then briefly talk about the cardiovascular control, respiratory control, and thermoregulatory function in these athletes. Some strategies to control the temperature and things to look out for and how to combat temperature dysfunction. And then from there, we're going to talk about boosting in spinal cord injury athletes, and then just overall recommendations for the spinal cord injury athletes, and in with regard to the autonomic regulation and dysfunction that these athletes can face. So with that, we can get started. So to start off with, as we briefly know, spinal cord injury can impair autonomic regulation. This can happen in the acute period, typically within 5 weeks. Hypotension, frequent episodes of hypotension can happen secondary to neurogenic shock, which affects about 20 to 30% of this patient population. Also, within this time frame, and then after the acute or subacute period, patients, depending on the level, can have transient episodes that include hypertension, among other symptoms, and this is also known as autonomic dysreflexia. This is pretty important as an athlete because depending on the level of the lesion, if it's if your spinal cord injury is at or above T6, you're at greater risk and have greater impairment of autonomic regulation. And we'll briefly talk on how, in athletes, that's pretty important to know in terms of your capabilities, in not only in the in-game moments that you have, but also leading up to that in training sessions and preparing over the long term too, and seeing what you're able to do physically and what limits you might have. And then, from there, we can talk on the cardiovascular and respiratory control, impaired thermoregulation, heart rate, and blood pressure. So in these patient population, typically you'll have cardiovascular responses like heart rate and blood pressure that are pretty crucial to athletic performance. But like I mentioned earlier, this can have autonomic dysregulation and lead to not only cardiovascular, but also bladder, bowel, and temperature dysfunction. So, individuals with cervical or high thoracic spinal cord injuries, they face lifelong abnormalities in, controlling the systemic blood pressure. And I think there's ways that we can combat it. And there's been things that have been done, studies that have been trialed in the past to combat and face some of these barriers that athletes can face. So specifically for the general spinal cord injury athletic population, how you manage these symptoms and how you manage the autonomic regulation. This has a huge impact on the quality of life, your endurance in training sessions, the recovery after games, and overall performance that you might have. And this is a pretty prevalent topic because there is a growing number of individuals with spinal cord injury and participation in sports, and this is increasing at at an all time currently. And there's been more involvement from the international committees, including the Olympic Games, to be more inclusive of these athletes. So I think really knowing this from the earlier, from earlier on with like younger patient populations, but also just like being for the general population to be more aware of things to look out for. So we can move forward and just talk about autonomic markers relevant to sports performance. So there's a couple ones that I put out here. There's more too. I think the first one I want to touch on is heart rate variability. Essentially, this is the overall balance between sympathetic and parasympathetic, and overall, like generally the higher heart rate variability that you might have, this can generally lead to what some might term like better recovery or end adaptability, and this really relates to the athletic performance in an athlete, where it might indicate the training adaptation that someone might have and their recovery status. In terms of heart rate recovery, this can equate to at times to like autonomic tone. Generally, like if you have a lower heart rate recovery, this often indicates a greater parasympathetic dominance in terms of your autonomic system. So this in athletes can be used to monitor overall like cardiovascular efficiency. Sometimes like it's an important marker in overtraining and fatigue as well. And then in terms of like blood pressure responses, this is pretty important as well, particularly in the spinal cord injury patient population, because it relates to the barrel reflex function and sympathetic activation. So abnormal responses with the blood pressure can suggest impaired autonomic regulation. In uninjured individuals, there is plenty of research that's been done that shows like aerobic exercise training increases barrel reflex sensitivity, and also enhances like the parasympathetic tone that I mentioned earlier, and improve overall like orthostatic tolerance. In contrast, individuals with like aerobic exercise training in the spinal cord injury patient population isn't fully understood. So that's where there's ongoing research. And we'll get a little bit more of like how blood pressure relates to other topics that I mentioned as well. And lastly, for sympathetic skin response, this is dependent on like the level and completeness as it relates to spinal cord injury patients, but mainly the vasomotor and pseudomotor regulation are proportionally affected by the level of injury. And I'll get a little bit more into the details of that and how that's important. And as you can see on the image on the right-hand side, it's just, you can kind of see like what we talked about, where exercise training overall kind of like touches on these 4 parameters that we talked about, where you can see that it increases the barrel reflex sensitivity. It has a positive effect on or it decreases blood pressure. And also, as you can see, I don't know if you can see the under exercise, that it has a positive or increases a parasympathetic response and decreases sympathetic activation. And then in the like cardiovascular function, you can see that it decreases heart rate and has effect on the cardiac size and function as well, both increasing for that. So these are pretty important markers that there is ongoing research relating to spinal cord injury athletic population, and seeing which of these parameters is beneficial, and like how training can adapt to with these parameters. So to briefly talk about cardiovascular and respiratory control, there's these athletes, specifically in spinal cord injury patient population, can experience cardiovascular autonomic dysfunction. This can be due to a decreased level of supraspinal sympathetic excitatory and inhibitory control of the heart and blood vessels. So this relates to abnormal sympathetic vasoconstriction within the body regions that are affected, Overall, this causes reduced venous return, limited stroke volume, lower systemic blood pressure, and orthostatic intolerance, and impairs the blood redistribution capacity that an athlete might have. And to further along that, they might also have, depending on the lesion, impaired sympathetic innervation to the heart. This essentially would decrease the innervation that one might have, or the output that one might have, the extent which is determined by the level and autonomic completeness of the lesion. So this can cause decreased maximal heart rate during exercise, and this has been noted in individuals with cervical and high thoracic lesions, and has also an impact on the cardiac output as well, since that's defined as the heart rate and stroke volume. So they can also experience decreased cardiac output in comparison to able-bodied population. And the mechanism is still being studied in terms of how that particularly happens. And then there are strategies to improve performance relating to this, and I'll briefly name a few, but anti-gravity suits, abdominal binders, electrical stimulation of the lower limbs, and hybrid functional electrical stimulation, as well as lower body positive pressure have been found to show some improvement. But for the most part, in the studies that I was looking at, none of them have been too conclusive. I think one that's pretty promising and has shown positive effect is the electrical stimulation. But that's something that's resource. It's difficult for patients that are resource limited to have access to that. Something like abdominal binders have shown to be beneficial, but overall, it hasn't had overwhelming strong evidence. Other than that, and then just to touch on respiratory control as well, there is, I think respiratory function plays an important role in impacting the performance of athletes with spinal cord injury. It is an important contributor to maximal exercise capacity, where peak oxygen uptake holds an inverse relationship with the spinal cord lesion. And this is likely due to the functional mass that is recruited during exercise. So essentially, individuals with higher level spinal cord lesions have reduced rates of ventilation. And that's also due to impaired innervation of critical respiratory muscles. Other than that, we're going to touch on the thermoregulatory function. This is a slide that I thought was very helpful. I'll talk a little bit and then relate to exactly where, I don't know if you can see my slide or not, but I'll try my best to kind of pinpoint where the area and the infographics that we're talking about. But thermoregulatory function is very variable in athletes with spinal cord injury. This is depending on the level and completeness of the injury. So as you can see in the image, in the blue, in the left-hand image, and then you see the spinal cord, and then the two patients there. You can see the tetraplegia in blue and the paraplegia in green. And we'll use these references throughout for this image, at least. So overall, in this patient population, there is reduced afferent input to the thermoregulatory center and a disruption of both vasomotor control and sweating capacity. So as the level of spinal cord injury increases, the area of sensate skin decreases with both the afferent information regarding the thermal state and the efferent response being reduced. So as you can see, the tetraplegic individuals with complete lesions demonstrate little or no sweating response due to the cervical spinal cord injuries being above the sympathetic flow. And you can see this relating to both the lab setting and the game setting. So as you can see down at the bottom, and you can see lab setting, they did 60-minute intermittent sprint exercises for the tetraplegic patient in this setting. He had a higher increase in core temperature change compared to the paraplegic, and the distance covered was less. And for the game setting, it's pretty similar, and this includes indoor wheelchair rugby matches, averaging about like 70 minutes. So the distance covered here was about 4.8, and the core temperature change was significantly greater than the non-SCI patient, which covered more distance and didn't have as great of a change in temperature. But both for tetraplegic and paraplegic, they have decreased sweating responses, although more is noted in the tetraplegic patient, and then they both have decreased blood flow control as well. And just of note, these patients also experience reduced afferent input into the anterior hypothalamic nucleus, which is the thermoregulatory center within the brain. So overall, within these changes, this corresponds to an increased risk of post-exercise hypothermia compared to able-bodied controls. So, all these impairments that the athletes might face, they need to try to combat that with possible solutions to not overheat and still be able to participate in sports, which is very important to these athletes. So briefly in this slide, they touch on using an ice vest before exercise and water sprays during breaks and play. So with that, they had a little bit. The distance covered was the same as no cooling, but they did have a temperature change of 0.6 Celsius, lower than not cooling at all. So although like they weren't able to do more, they reduced the risk of some of the adverse effects that we see with overheating and increased temperature. So I'll touch a little bit more on the strategies to control temperature. I labeled a few on the left-hand side, hand and foot. So limb cooling, we have a cooling vest, a cooled headpiece, and water spray bottles. And on the table, we can kind of go on like the logistical issues, practical issues, and then advantages that this might specific strategy might have. So for fans, they're likely coupled with skin wetting to be effective in hot conditions, but this can produce a dissociation between thermal perception and thermal strain. So this can increase the risk of hyperthermia. Otherwise, it's pretty easy to use. It's portable. It really doesn't have any adverse effects. So I think the use of this in athletes is pretty common. The second one that we can talk about is the water spray. This has to be paired with like an airflow or like a fan to kind of like allow the vibration of water from the skin. And to see a positive effect, you do need to apply at least 50% of total body surface which is required to be effective to have a cooling stimulus. Some of the advantages that this might have, it mimics the sweat response. It's easy to use around training and games. Each athlete can access it at the same time, so it's very accessible to everyone, and there's no adverse effects noted. Then moving on to ice vest, this is a little bit more a little bit more difficult because it requires higher logistical like preparation. So it requires cold storage for use. It's really hard to implement garments into athletic clothing for actual competition. And sometimes the competition, depending on like the game that's being played, sporting regulations might not allow the use of this. And then there's the downside where like depending on the event and the game, the cooling effectiveness is reduced when the cooling strips start to melt. For this, like some advantages, it's the largest body of research. It can improve performance from an athletic standpoint, and then it has a greater reduction of skin temperature than ice slurry ingestion, which is another form of cooling not included here. And then lastly, limb cooling. This is common in a lot of wheelchair court games, wearing gloves and tape to enhance performance. It's can cause hypothermia or trigger AD, or hypothermic overshoot and or trigger AD, but it's still pretty effective. It has a pretty great effect in reducing the core temperature just in 4 minutes. And there's differences in regional skin blood flow, meaning that some of the conductive cooling sites are more effective than others. So hands compared to torso. And there's a lot of research into limb cooling, not only in like the SCI patient population, but also in able body controls as well. So, I think and what I mean by that is that there has been studies in the past for limb cooling that have shown in able-bodied individuals for it to be an effective cooling method. But I think there's a difference in the thermoregulatory function, like we talked about earlier, where in able-bodied controls, they're able to drive, they're able to have more vasoconstriction through the hands and feet, so it has a better effect. But still, it's pretty well studied in the SCI patient population as well. So overall, I think like these are all local cooling methods, and I believe it's useful in reducing the thermal strain that these athletes might face, and limit the adverse effects of hyperthermia. So, and now to touch on boosting, which relates to the autonomic regulation that we talked about earlier. I'm not sure if I think many people are familiar with like the pharmacological doping in sports. We kind of like read about it here and there, both in like soccer, basketball, and baseball as well. More common in the 90s, a little less common today, but there's a lot less awareness about boosting. And this is defined as an intentional induction of autonomic dysreflexia by athletes with a spinal cord injury at or above the level of T6. And the goal of this is just to improve sport performance. So they may induce this by essentially like inducing the dysreflective state. And this reduces the rate of perceived exertion and increases top wheelchair speed. So this was first banned in 1994, and it continues to this day. There's been stricter regulations as of late, which I can get into. But essentially, this was banned because I think there's specific patients in the SCI, depending on like the level of lesion, that patients may be able to boost, and it causes an unfair advantage compared to the other athletes that are participating. Specifically, I think boosting relates to high intensity court-based sports and middle and long distance races. So this is where it's more common to see boosting in the past and to currently see it today. So you see about 10% of performance gains overall, and there are health risks to this, which is why not only the committee, but there's been a greater push to increase the awareness of this, not only in elite athletes, but also in the community and the more community-based athletes to reduce the health risk that boosting can cause, which includes, but not like also like not limited to stroke, seizures, cardiac arrhythmias, and death. So there is testing for boosting, and there is a current regulation to detect boosting. So essentially, what the IPC, or the International Paralympic Committee, recommended is to test the athlete's blood pressure before the competition. If the systolic blood pressure was found to be above 160, then the individual is re-examined 10 minutes later. If it's still found to be above 160, then the athlete is withdrawn from the classification or from the competition. So this is something that's been a push as of late. And even though with this regulation and these checks, I think there's still a way that athletes continue to boost. So there's been, talks of having like stricter guidelines for athletes performing in these high level competitions. And lastly, I think it's important to know that the classification system does not take into account autonomic function. And what I mean by classification system is the way the International Committee classifies a limitation for a Paralympic athlete. So currently the approach is that it's only the exclusive use of motor function for classification as for these athletes. But overall, like, I don't want to get into like too in detail, but it's a very detailed and it's a very complex and sport specific process. But essentially, with the exclusion of like visual and intellectual impairments, the use of its impaired motor control as the defining criteria for these athletes and not autonomic function, which is an issue because some athletes are able to boost, some are not, and that creates a disadvantage to those that can't. So really quickly, I know we talked about like boosting, but just kind of like a infographic in terms of like what you typically like can see. So it's similar. It's essentially like what can cause AD. So you can have bladder distension, you can have an injury or nauseous stimuli. So an athlete might be able to like tie a shoelace or a belt below the level of the injury, and this can cause the physiological responses. So you can have increased cardiac contractility, vasoconstriction, and blood pressure increases as well. And the heart rate might be variable, but you can usually see bradycardia or tachycardia depending on the degree of the stimuli. And we talked about the dangers, but these include hemorrhage, ischemia, seizures, arrhythmias, and death. So even if a patient doesn't have these severe cases, like these adverse effects, the daily exposure to these athletes in those that like don't have symptoms can present a substantial long-term health consequence. And then, like I mentioned, the act of boosting has been reported to enhance performance by about 10%. So this is like an ongoing topic, but it's something that not only the spinal cord injury patient population should be aware of, those that are interested, but also the general population as well. And to close off and to finish, I think just overall recommendations for spinal cord injury athletes. I know these are like, we talked about a lot, but I think just overall, tailoring the cardiovascular training and standardizing thermoregulation protocols, I think this is pretty important. It's dependent on the sport and individualized, but I think having recovery programs that address specific autonomic deficits will be very helpful in these athletes. I think increasing education regarding boosting, particularly educating coaches, support staff about the signs and risks that can help, not only in the, I think it's pretty known in the international or like the elite athlete population, but also in the community-based high school and higher level education. I think it's pretty important to continue to provide strategies and education to these athletes that might not know. Lastly, I think there's been a push and studies to integrate autonomic function into the classification system that I briefly talked about, using some assessments that we talked about, such as the sympathetic skin response or the static blood pressure monitoring to better categorize athletes' functional capacities. Right now, the IPC, so the International Paralympic Committee, understands the limitations that the current classification system has, and they are looking into ways to adapt. But I don't think there's been any formal discussion in terms of integrating autonomic function, but I think there's been a push in terms of like truly understanding how we can better standardize those and integrate autonomic function into the system. And lastly, just continuing research in this patient population and autonomic function. I think it's critical. There's studies that have different training methods with different levels of lesions, both in the acute phase and the inpatient side and the chronic over, a year out from injury and how that relates to autonomic function. I think it's pretty hard to do research in a patient population and finding like the appropriate participants that fit the criteria, but I think it's crucial to continue to do and to move forward with improving the overall health of these athletes that want to participate in sports, and with the goal of like improving their like understanding and improving autonomic function in these patient populations. So with that, I am finished. These are some of the resource references that I've used. And if you have any questions, feel free to ask. But thank you so much for listening, and appreciate the time.
Great. Thank you so much, Juan. Let's open it up for any questions.
Yeah, great job, Juan. I don't know if we have any questions right now.
Well, I thought it was really incredibly thorough, and I think you touched on a lot of different aspects. As a future physician who may be working with athletes in wheelchairs, if you're seeing these patients in clinic, what are you telling them? Like, or before they want to start sports, what how do these come into your kind of practice with thoughts?
That's a good question. So I think overall, like asking them if they were an athlete before the injury, kind of like seeing where they were at in terms of their like cardiovascular function, their level of training, the type of athlete that they were. Is it more casual, or is it intense college or above that? And then if they are not that, kind of like differentiating between like where they were at previously and seeing what their goals are. So if it's someone who just wants to like be able to play with friends, I think that's a very different conversation than someone who wants to be able to play college or train for the Paralympic Committee. So I think having those discussions are important, and then kind of like conveying what we talked about here in terms of the level of injury. You can see there's clear differences in terms of the training that you can do. So then I would like talk a little bit more about like those specifics, but just kind of like seeing where they come from, their goals, and kind of like what we talked about here earlier, just knowing the impairments that someone might have depending on the type of lesion the level of lesion, and the type of symptoms type of lesion that you have. Yeah.
Any other questions? Well, again, great job. I think this is a really exciting patient population and athlete population to be involved with for anybody who's going into sports medicine. You can really get to know some really great teams and travel and do a lot of exciting things. There's also in September a AAPMNR and Paralympic Sports Medicine Conference that's going on in Colorado. So maybe some opportunities there. I think you can even present to it. So I would take a look at that conference if you're interested. Otherwise, thanks again. All of our prior bi-monthly in-service presentations are available on YouTube. And thanks again, everyone. Bye.
Thank you.